Good afternoon, everyone. We are very welcome you here now in the second EFIM webinar. EFIM, as you know, is the European Federation of Internal Medicine, and internists in every single country are the ones who are together with with infectologists and other specialists are in the front lines of the fight with the COVID. We decided to organize this webinar not so much concentrating on the most recent trial data in details, but more about a short presentation about the challenges, own experience, trying to answer your questions. We have three outstanding speakers, and the first one will be Professor Xavier Corbella. The second one will be Assistant Professor Valentin Kokorin from Moscow, and the third one will be Assistant Professor Alberto Marra from Napoli. And we will go like one by one. Let's see how we are doing with the time. So approximately between 10 and 15 minutes for each speaker. And depending on the questions in the chat, we will also ask them directly or after all three speakers have been done. Before we go for the challenges, before we go for the talks, I would kindly ask everyone, please mute your microphones. And we have during the presentations we have switched on also cameras for the listeners. It's not like we don't want to see you, but we are just trying to avoid background noises here. We will welcome you all back afterwards. If you have any questions, send me in private chat during the Zoom, or write in a chat to everyone. We also go in a Facebook Live. Hopefully it goes. All webinar is there online. So let's see how it runs. And with this one, I'm giving the floor, or I'm giving the ball to Xavier Corbella from Spain, Professor Corbella.
Okay, thank you very much, Eva. Thank you for inviting me to be here in this second webinar. I will try to share my screen. Here you have some recent data regarding the epidemic situation in our country, in Spain. Today, these are data from this morning. We arrived to the 3 million people infected across the world, with 200,000 deaths and around 800,000 people recovered. In Spain, as you know, is the second only to the States, with 226,000 people infected, and we are third behind the States and Italy in the number of deaths, with 23,000 people dead until now. This is the distribution of different European countries, showing how Spain is in the second position, unfortunately, but very close to Italy, to France, and now Germany and UK. But the difference is especially Germany, with these low rates of deaths in comparison with our deaths of Spain, Italy, France, and UK. This is Spain, Madrid, was one of the hottest zone, and Catalonia with Barcelona here, that are the second one. So Madrid and Catalonia has been the regions with the highest rate of people infected, and less in the south, as you see. This is Andalusia, Sevilla, or the north is the Basque Country. So the distribution has been differently depending on the region, as other countries, as Italy or other countries. These are some numbers. We now have 16% deaths and 84% recoverings. This is the evolution of the trends in new infected cases. We started at the end of February. The first case in Spain was on February 25th, and was 2 patients coming from Italy in Madrid and Barcelona. And this has been the evolution of the trends in new cases. And now we saw this slow decrease day by day. So we are considered that we curbed the trend, and we are now in the decrease phase. But we have to be very careful, because we don't trust that this has been solved. So we have to be very prudent. On the right of the slides is the curve of the deaths, the dead people, that similarly to the new cases, we are in the decrease phase. But this is controversial, because as you know, the count of the number of deaths depends on the criteria of each country. If you only count people dying in during hospitalization, or people that are that lives in home care or residencies, and this has been difficult to compare countries by countries. But in any case, we are in a decrease, and so we are in the end of this disease phase. These are 2 cases that I want to show and to share with you. These are 2 people from my staff. I am the head of the internal medicine department, and these are 2 of my staff suffering the disease. This was a 63-year-old man. This is a physician of my team that started with fever, cough, and myalgia and fatigue on the day 0, March 13. After 4 days was a weekend, and on Monday he knew that was PCR positive, but started with high fever. We decided to perform an X-ray that was considered normal. His saturation was 97%, and we, at that time, that was at the beginning on March, we decided to give on hydroxychloroquine and azithromycin per 5 days. But he stayed at home. The evolution was not good. On March 25th, 12 days after presenting the symptoms, remained with high fever, 39 Celsius degrees, but saturation started to decrease, and one infectologist decided to start with Caletra. But the clinical evolution was in progression, and finally we decided to admit him at the hospital, showing that the PA/VI was less than 300. All the inflammatory parameters raised, and the X-ray was this one with infiltrates, bilateral infiltrates, and he was admitted in a conventional ward, not in the ICU, and we decided to start with tocilizumab and corticosteroids. We can talk about later this. In Spain, we are very restricted for using tocilizumab, and only one dose could be administered. And after 6 days, he recovered completely and was discharged. Another case is a young physician. He was 36 years old. He has been in contact with many patients in the front line of the hospital, and he suffered suddenly for fever, cough, and weaknesses. But the X-ray was the second day was considered normal. But when we reviewed the X-ray, we considered that this spot was not normal. I'll show you here. Is of course is difficult to see in the first view. And we performed a CT scan, and the CT scan showed this clear infiltrate and lung injury. As many of you know very well, that CT scan showed better all the injuries in comparison with the normal X-ray. Was a mild infection, and he recovered after 10 days, and he didn't need tocilizumab and any other anti-inflammatory or immunomodulators, only given on hydroxychloroquine and in this case, Caletra, because was a time that we didn't have remdesivir, that we are now doing some randomized clinical trial, as many of you. Well, this is my two last slides. This is the evolution in my hospital. These are the number of the emergency visits throughout the pandemic. The pandemic started in March 13, March 14, and these are the evolution of the number of emergency visits and the proportion of COVID patients in comparison with non-COVID. So now we are here, only 6% of patients visited at the emergency department has suspicion or confirmed COVID. So we are also viewing that the pandemic is in the decrease phase. And this is an interesting picture showing the proportion of patients admitted at the ICU compared with the semi-critical care units and conventional wards. In blue, you have conventional wards. In red, you have semi-critical. This means non-invasive ventilation. And in green, you have intubated patients admitted at the intensive care unit. So the peak was achieved on March 28th. The proportion at that time was 150 patients admitted in the critical care areas in comparison with 400 people admitted in the normal and conventional wards. My hospital has 750 beds, so almost 80% of beds was completely occupied by COVID patients. Now the situation is better, but we see with our worries is that people admitted at the intensive care units and the critical care units are not decreasing, are remaining stable, an important proportion of them. So we suspect that a high proportion perhaps will die, and the others will need an important and heavy rehabilitation process So we are waiting for this discharge that will go to the conventional wards, and the internal medicine department will be, of course, the department of destination. And this is my last slide. This is the comparison between those new cases with new deaths, is in yellow, and new recoveries in green. So now we have a greatest proportion of recoveries compared with deaths, but this was in the middle of the pandemic that was completely the contrary. And this is my team. This was the first day when I was speaking with Nicola, who was the first of us suffering the pandemic. And he explained it to us that the sessions have been canceled and people have to wear masks. And I couldn't believe that, but this was the reality of our service. These sessions has been canceled completely, because we cannot stay in the same room like this, but this was the first day, and was the picture that we will remember for the rest of our lives. No? So thank you, and I am open to your questions.
Okay, thank you, Xavier. Are there any, we will try to unmute people.
Yeah.
Unmute all.
Ya, quédate
With a
Maybe we will have a questions in the end after all three presentations. What's happened?
Okay.
Okay. Yeah.
Okay, we continue.
Valentin, is Valentin will continue?
Yes, I will. Good evening, everybody. And I will tell you a few words about the current situation with COVID-19 in the Russian Federation. I will say that in contrast with West European countries, we are now only on the growing phase. So from one side, this is a more nervous situation, but from the opposite hand is that we have a possibility to study experience of our colleagues from Italy and from Spain, and I will show that in some moments we were really very good prepared to this pandemic. My disclosures for today, we have on this map numbers of cases in different parts of the country. I will tell a few words later about that. But I will say that Russia is all this a mystery, and here is an example. We had a first confirmed case of coronavirus of 2 Chinese travelers which were registered in the very end of January. But the second confirmed case, it was really a Russian who came back from Italy as a tourist, and it was 1 month later. So for almost all the month, there was no confirmed cases of coronavirus in Russian Federation. So for today, we have almost 78,000 infected patients with COVID, and more than half of them are in Moscow, just in one city. We have not so high numbers of recovering patients and just approximately 1% of deaths. You can see on the map that mainly the more often cases are happening in European part of the country, and much less infected patients are in the eastern part of Russian Federation. So you can see that we are still growing, and for the last days, the approximate rate is 7 between 6,000 and 7,000 infected patients every day. We have increasing number of deaths, but the number of deaths not exceeding 70 per day till today. And here is the 5 top coronavirus regions in our country. It's Moscow and the suburban, the region around Moscow. And it's, I think, almost 60% of all cases in our country was registered only in Moscow and surroundings. But the other focuses are in the north, St. Petersburg, in the south, Dagestan, and in the middle on Volga River, Nizhny Novgorod. And in all these regions, the approximate level of mortality is 1%. Epicenter of the epidemic in Russia is Moscow, and you can see the diagram with the number of COVID patients, new cases per every day. And for the last week, we have nearly the stable situation between 2 and 3.5 cases every day. Our government made a regime of self-isolation since 30th of March, so now it's almost 1 month. And in Moscow, we really had very active transformation of clinical hospitals to the COVID centers. Almost 60 federal, municipal, city, and private hospital was restructured for COVID patients. And today we have a capacity of 22,000 patients totally in Moscow. And in the beginning of this epidemic in Moscow, I was sent to a Russian Clinical and Research Center of Gerontology as a consultant for this period, temporary. And at this period, the center was restructured for approximately 2 weeks. And it's not so huge like big hospitals. We have a capacity of approximately 150 patients. We have 16 intensive care unit beds. And we have totally 21 ventilators. So we work only 10 days for the epidemic, and we had now 155 patients. 15 of them was already discharged. We had just 1 case, fatal case for this period. And for today, we have only 13 patients in intensive care. 9 of them are on ventilator machine. So we have a routine protocol for our patients in our center, which includes hydroxychloroquine plus azithromycin or lopinavir, ritonavir. And all the patients are prescribing heparins, mainly enoxaparin, in prophylaxis or full dose for all patients who are in severe condition or have any other indications for anticoagulation. We use full doses, and we also administer acetylcysteine. We have also other additional medications like acetaminophen for fever, antibiotics in case of suspected bacterial infection. We have tocilizumab, sarilumab, and also oxygen supply, non-invasive in many wards. So that is our experience at the moment. I would like to finish my presentation with the words of Haruki Murakami. I think this is very suitable for the current situation in all the world, that the storm is over. When it will over, you won't remember how you made it through, how you managed to survive. You won't even be sure whether the storm is really over or there will be a second wave of epidemic in the future. But one thing is certain: when you came out of the storm, you won't be the same person you walked in. So that is all the storm about. Thanks for your attention.
Thanks to Valentin. I will still repeat. If you have some questions, like individually or to all the speakers, please write in chat or send me or because then it's easier to ask them to everyone. And we have already collected a few. We will ask them after the last presentation, who is given now by Alberto Marra from Napoli, from Italy. Please, Alberto, the wall is yours.
Thank you, Eva. Good afternoon, everybody. As Eva said, I came from Napoli and from Italy, and I will try to give you our perspective from one country that was hit by a huge outbreak of coronavirus, but still from a part of the country where we didn't experience that huge outbreak. Also in my case, my ward, the internal medicine ward, we were warned at the beginning from the direction of hospital to be prepared in becoming a COVID ward. But at the end of the day, up to now, we weren't needed to serve for this outbreak, since the data in my region were really good. I will try to give you how does it feel from our perspective. And as maybe lots of you know, the story started in a particular day for me, because it was also the day of my birthday, when this guy, healthy person, was admitted to the emergency room for this interstitial pneumonia. And after the intuition of one anesthesiologist, it was found to be associated with coronavirus. And this guy was named patient number 1. We struggled in finding the patient 0, but at the end of the day, after 2 months, we are quite sure that probably this guy was not the patient number 1, but probably the epidemic was already all around. And as you can see from these graphics, these are the data that I collected up to yesterday. We experienced a huge rise in the numbers of patients who were infected. Sorry, I had a problem. Okay. Infected, to those people who are active positive, and also a huge case fatality rate that was up to 10% in some cases. And as you can see from this data, you can see how, in comparison with last year, we experienced a very dramatic rise in the number of deaths, which means that probably the impact of this outbreak was really strong. And there were some research initiatives that probably can be useful also for other countries. And I would like to share you this Voeoganio. Voeoganio is a small village in the region of Venezia, and I called the sort of Framingham study of COVID-19, because it was a population study where all the village was screened and tested with nasopharyngeal swab. These are a very interesting data, because almost half, there was 2 rounds of screening in this study. Also, half of the people found positive was completely asymptomatic, which means that probably those people could be somehow who helped spreading the virus. And as I told you, and probably you know from the media, the huge concentration of the epidemic was in the north of Italy, while in central Italy and southern Italy, it was relatively lower. Indeed, those are the data. As you can see, the blue line is North Italy, are the number of infected. You can appreciate the huge difference from northern Italy, with central Italy in purple, and the light blue line, which is southern Italy. And this is the same also, as a consequence, also with regards to deaths. As you can see, there's a huge difference between the 3 parts of the country that have almost the same number of inhabitants. There's some theory and hypothesis regarding this data. One is this one: probably there's a huge overlap. You know, the north of Italy is the most rich and developed part part of the country, where all the industries are, where all the manufacturing are, where all the business is. So probably this huge concentration of business and economical power probably led to have more meeting and more contact between the peoples. Indeed, there is a strong overlap between where are the centers of industry, manufacturing, and where the infection were. Of course, this is just one of the lots of hypotheses. Another hypothesis is about air pollution. Of course, this should be probably confirmed by strong and robust epidemiological analysis. In our region, we did a very, very important social distancing. This was one of the messages from our governor. And those guys would like to send flamethrowers. Sorry.
Notizie che qualcuno vorrebbe preparare la festa di laurea. Mandiamo I carabinieri, ma li mandiamo con I lanciafiamme.
So it was quite strong media campaign, probably too strong regarding social distancing. We had, but how we cope with this story? Basically, we were able, since the low number, to manage almost the majority of COVID patients in some COVID hospital. There were some hospitals which has a strong story and tradition of infectious disease. And since the number were really low, we were able to manage those patients just only in those hospitals, mainly, of course. And this is one, the Cotugno Hospital, which has a long-standing tradition in infectious disease since the era of hepatitis, cholera. And in this hospital, since they are used to wear those protection equipments, they, and also Sky and the BBC told about, they were able to not have any healthcare worker, doctor, nurses infected by the coronavirus. So probably this was also one reason why we cope with this infection. This is how we manage in our internal medicine department. As I told you, we weren't a COVID ward, but we were somehow involved, of course, in keeping those patients after the acute phase, the so-called post-COVID. So those patients from the COVID ward with 2 negative nasopharyngeal swab were sent to the internal medicine department to do some recovery, administration of therapy, and of course, this was a way to let the infectious disease ward to have more free beds. We had, this yellow was a room where we do a sort of triage, and this is me, and this helmet was done by my father. And this is the way where we admit the patients with suspected COVID. We admit the patients, we did the clinical examination, we performed a 2-minute walk-in test because it was very sensible test, blood gas analysis, lung ultrasound, and of course, rapid serology and nasopharyngeal swab. And then after that, the patient was labeled as non-COVID, we could admit in the internal medicine ward. My hospital also provided a psychology service for doctors, and it was through Skype, and this is very important because I guess that the burden of burnout in this particular time of our history, it's very huge. It was for me very hard to manage residents and colleagues and the relationship between colleagues, because even if we didn't have such great outbreak, the stress was really, really huge. And you know, it's like being in a war, not on the front line, but a little bit aside, and still with the tension that you are waiting the enemy to come. We did in my group also some research proposal. This was done by my mentor, and it was a proposal to try to support and improve the care done by the primary physician, since we do believe that the GPs may play a really relevant role in starting the diagnosis process at home of the patient and probably start also therapy, although of course there's no evidence-based therapy to date. And another story, there were lots of friends contact me in the last months. It was about tocilizumab. Also, Valentin and Xavier told about this drug. This story started in my city from a group of doctors, and I would like to stress how important is the interaction between different areas, because the doctor who started the tocilizumab were a group of oncologists, since they were used to administer tocilizumab to patients with leukemia. And there was a huge interaction between the oncologist group, which I'm really linked because it's the oncology ward that treated my mother as when my mother had the cancer, and the huge interaction with the infectivologists. And they started this off-label therapy. And the first data were really, really enthusiastic. Then the Italian pharma agency, it's like our FDA, IFA, started this protocol that is actually running. There were some press release with very, very good preliminary results, but still we are waiting the final publication of the study. Of course, tocilizumab should be administered in those very severely ill patients, and is a very huge doses. I spoke with one of my colleagues from Germany. She's a rheumatologist. She was impressed by the doses because in rheumatoid arthritis, it's very, very lower. But indeed, I had some colleagues who received tocilizumab, some patients who I know, and then in my experience, it was really powerful treatment in those patients. And some of them were able to avoid intubation, thanks to probably to tocilizumab. We, with some friends, we tried also to make some hypotheses about what will happen afterward. Is COVID just an acute disease, or probably is associated with some chronic complication? Of course, actually, we do not know. We thought about the immune cell infiltration, the role played by the immune system, and also the role of coagulation. Indeed, the heparin is also discussed as a potential therapy. We actually don't know if those patients, during the time in the long-term follow-up, will develop some complication. One hypothesis is pulmonary fibrosis. Indeed, some patients discharged at the last CT scan present some kind of lung scarring. And also, I'm finding also with echocardiography, some patients that have a slightly dilated right heart. And probably it could be that somehow they could develop a sort of chronic thromboembolic pulmonary hypertension. Of course, this should be proven. It's just a hypothesis. And what do we do after? I mean, once the patient has 2 negative nasopharyngeal swab, and then we admit in our internal medicine ward, and then we try to start. CT scan, we prescribe a CT scan and echocardiography after 6 weeks, indeed, because to avoid and rule out those chronic complications. We prescribe to check out the coagulation state. We prescribe respiratory rehab and exercise rehabilitation, and of course, psychological, and think about the social impact. It was not a normal disease. It was a disease with a huge social impact. All the media talked about it, and it was a very, very painful moment. And it was painful also for us, because even if we were hit really less than Northern Italy, also in my city, we had to pay a tribute. And in this regard, I would like to remember one person, which is was a very inspiring person to me, Professor Maurizio Calderisi, who was one of the most relevant echocardiographers in Europe and in the world. And unfortunately, he passed away due to this very bad epidemic. And I would like also to remember Maurizio Calderisi, and hoping that he will look to us from above and guide us in the future. So thank you really much.
Okay, thanks to Alberto. We have already some questions, so we please one more time, if someone has already more under the slave, please write this in chat. I'll just And Alberto, unshare the screen
Yeah, sure. Sorry.
so we can see the people. So there's one question. I will start because it's specifically concerns the case what was mentioned by Xavier. Xavier, need to unmute.
Yep.
Yeah. So Xavier, there was a question regarding your case. This was about a doctor who was working in the very difficult high level or high level of the infection, or is it some misuse of personal protection equipment?
Excuse me, can you repeat the question?
As far as I understand, the colleague has asked the question. Is it about someone who worked without proper safety equipment, or was it some mishandling with this?
The two cases that I presented from my staff. Yeah, one case was the elderly person has no contact with any patient because we decided that people over 60 had to remain at home and not being in the front line. But his partner was positive. It was a nurse, and the nurse was positive and was the case that infected him at home, was not in a hospital. And the other case was the youngest is a staff of 36 years old that was working in a very, very difficult units, not from my hospital, from the hospital that we have in front, that is a long-term care facilities with many people that was elderly people, chronically ill, multimorbid people without testing, and they didn't know at that time how many of these patients were positive. So he arrived late, and when suspicion arrived, most of these elderly people and chronically ill patients admitted at these long-term care facilities were positive. So, but in both cases was non-directly infected during hospital tasks.
Okay. The second question also to Xavier. Was there indication, what was the indication for the glucocorticoids, what was given?
Yeah, this is a very controversial issue. Of course, today we don't have still any recommendations against or in favor, but we strongly believe that in this second week or third week of disease, when the storms of cytokines arrive, and when we see the lung injury with these severe patients, we decided to establish some criteria to start immunomodulators and immunosuppressors like corticosteroids or tocilizumab. As many of you know, the only report available till now considering tocilizumab is from China, only 21 cases. Now there are arriving more cases. It was not a randomized clinical trial, so many limitations have to be remarked. But when you don't have any options, this is the only that you can give to your patients. So our government and our Ministry of Health authorized the indication of immunosuppressors in this phase of at the 12th day from the beginning of the symptoms, or in the second or the third week. And we gave corticosteroids together with tocilizumab. In my hospital, we treated more than 200 patients with tocilizumab. The experience together with corticosteroids has been successful. We are waiting for some, of course, retrospective analysis. This was not a randomized clinical trial. and we are comparing with a control group. But our impression is that patients recovered and avoid intensive care unit admission when you give these two drugs in the late phase of the disease, not at the beginning, because we don't have, as you know, antiviral agents in enough active to protect the patient from immunosuppression. But when we think that the viral replication decrease and the damage is essentially the lung injury down by the inflammation, we decided to treat these patients. And as Alberto Marra said, our patients under these therapies avoided intensive care unit admission, and mortality among them is around 10%. So we gave corticosteroids together with other immunosuppressors in this late phase of the disease. And usually we only give 3 pulses, so 3 days with methylprednisolone at the doses of 125 or 250, but only three days, not to be sure that while waiting for the randomized clinical trials, we will have more information. The previous data coming from the SARS-CoV-1 and MERS was not successful, so we have been very prudent. But actually, our decision is now to maintain this criteria to allow the administration of corticosteroids in this phase of the disease.
Okay, thank you.
I would like to add a few words, if possible,
okay,
to Xavier. I will say that corticosteroids is mostly important in severe patients, in patients with septic shock or with the acute respiratory distress syndrome. In such patients, it's not obligate, but it's favorable to use corticosteroids. But in other cases, if you have no other options, if you used other medications and you get no success, you can also use corticosteroids. But indeed, there is no randomized trial at the moment, so that is a problem. But in severe patients, we usually use steroids.
Well, we of course totally agree. We consider this like how to say this secondary hemophagocytic lymphohistiocytosis syndrome associated to this viral infection. The criteria on the support to try to treat with these immunosuppressors. But of course, we need randomized clinical trial. Now, as you know, there is some of them ongoing testing tocilizumab and also associated or not with corticosteroids. And these are the data that we need to firmly support this criteria. We have only this real world data, these observational data, but we treat a lot of patients, and we are convinced that in this late phase of the disease and the severe patients with severe criteria could be clearly useful.
Okay, there's one more question. There are more. I tried slightly to group them. It's very short. It's more like yes and no question. Are you using remdesivir in your hospitals? It's a question for all 3 speakers. So who will? Alberto, go first.
Yes, absolutely. We are using together with hydroxychloroquine. Although the data are not so encouraging, there was a trial published on New England a couple of weeks ago. I do believe that this kind of therapy will be better probably in an early phase of the disease. Probably once the patient is admitted to the hospital, probably it's too late. But this is just my impression.
Yeah, I agree. The real problem and trouble is not to have antiviral treatments. We have no good experience with Kaletra, with lopinavir and ritonavir. And we have a lot of adverse effects. And we are participating in some randomized clinical trial of remdesivir. of course, is our hope that this antiviral treatment will work, because it's the only choice that we have to treat in the first days of viral replication. But we are waiting for it. In Spain, it has been very difficult to achieve remdesivir. Was totally controlled, and now under the clinical trials we can have this drug, but it has not been easy to have this drug in our hospitals.
In Russia?
And I will also say that we in our country we have a lot of Kaletra experience and not remdesivir at all. But as we saw, the effect of Kaletra is very low, so we do not use it routinely at the moment. And I will say that the situation is very quickly changing. For example, we prepared the protocol for treatment a week ago, and now a few papers was published which showed that the combination of hydroxychloroquine with the azithromycin is not effective too much. The antiviral medications are not so good as we suppose. So I think that today we have more questions and we have no clear ideas how to treat the COVID patients. We are trying different options. Some of them are more optimistic, other one are not confirmed. So I think we should wait a little and continue our trials, our scientific research to search for the best options.
There are a few more questions. There's one concerned drug abuse, people who are drug abusers. Do you see more severe COVID infection signs in people who are drug abusers?
Indeed, I will say that we had not so big experience with drug abusers. I will say that most of our patients are mid-ages and between 40 and 70 years old, approximately half to half men and women, but severe patients are mainly men. And what else? And mortality in men is much higher, and the doctors are one of the main risk groups, much higher than in others, in drug abusers or alcoholics or so.
May I add, Valentin, also obesity is a very
obesity and diabetes, yes, you're
devastating risk factor.
I have no experience in drug abusers. Our population is, as Valentin and Alberto said, we have elderly people, most of them over 60s. The only risk factors that we showed up till now was to be male and to have chronic heart failure as a previous diagnosis and chronic liver failure. And all the other data are very quite similar to the data that are ongoing in the rest of the world, but not specifically a higher proportion in drug abusers or included HIV patients. We didn't see many of them.
One patient, one colleague has had earlier asked me a preliminary question. So I will give that. There's a young doctor who is pregnant with the and positive for the COVID infection. Do you have any experience with the pregnancy and COVID infected patients?
Well, sorry, Valentin. No,
yeah,
just
you
to
can
tell
start.
that in the regional plan of my region, my hospital was also the one who admitted pregnant women positive to COVID-19, of course. So far, I guess yesterday they were the first delivery. It went, everything was okay. And I guess the baby was negative. And all the data I've read in Italy, I don't know in the other countries, are that it's not maternal-fetal transmission. Was not reported. Of course, this is a disease that we do know since 4 or 5 months, you cannot draw any conclusion. It's too early. But so far, I've heard that there's no risk for the baby. And also during the pregnancy, since age is also a very important factor, also there was not registered any poor outcome in pregnant women.
Yeah.
I will, oh, Xavier.
Oh, okay. No, it was the same impression. No more severe disease among pregnant women. No evidence of vertical transmission. Interesting data, I think, that is early deliveries. So it seems that pregnant women are not in a special higher risk compared with the normal or the other population. And I think that our worries could be if these treatments that we are using could be dangerous for the baby, and most of them, of course, we have very poor experience, but most of them are not especially contraindicated during pregnancy, like these new drugs or these antivirus. But I think that the idea in the world is that is not more severe than a normal delivery.
I will just add that due to our experience, one of my colleagues is obstetric specialist, and they have a big amount of COVID positive, not so big, but some of them are COVID positive, and there is no specific consideration with the delivery. In the usual way, not using cesarean operation for delivery. But the problem is the COVID infection in early stages of pregnancy. For such woman, sometimes it's necessary to perform abortion because it's a risk factor not for the fetus, but for the woman. And in such cases, this is an option to in severe COVID infection. In some cases, we perform abortion.
Okay. Thank you. More questions are about the anticoagulant use. So I think that's from just put in precisely. So yeah, Katerina is asking from Romania, could only high level of D-dimer be an indication for full dose low molecular weight heparin, or are there supposed to be also signs of severe disease? So D-dimers high only or plus severe disease?
May I answer? Because we just discussed it with my colleagues before this webinar, and we decided that we will prescribe full dose of anticoagulants, therapeutic dose of anticoagulants to the patients with D-dimer exceeding 1,500 to everyone. But we administer anticoagulants in prophylaxis doses to all admitted patients, to everyone. And in case of severe infection, in case of severe condition, we also switch to the full dose anticoagulation. And we usually use low molecular heparins. And in some patients with low creatinine clearance, we use heparin. Unfractionated heparin.
Okay.
In our case, quite similar. We decided this was controversial because these situation with coagulation is not clear. And from the internal medicine department, most of our patients are not so severe to be intubated. So we have a partial vision of this issue. But we considered full anticoagulation when criteria of course of disseminated intravascular coagulation are coming from the lab test and the clinical situation. And we use the parameters as usually. So we consider the platelet count, the dimer, the other criteria. And usually we decided to treat patients with half dose prophylactic and only full dose in these especially severe cases like Valentin said. My comment is that we recommend 14 days after discharge to maintain this prophylactic anticoagulation. And I don't know what is your opinion about that, because despite we didn't see readmissions associated with pulmonary embolisms or thrombotic, we think that this inflammatory status and this special state at the end of the disease requires to protect the patient with this prophylactic treatment during at least 14 days.
I agree with both of you. I mean, we also do the same strategy, which is for me not surprising because it's on the basis of a clinical thinking. Of course, if you have high D-dimer, you suspect pulmonary embolism or high thrombophilic state, you go with the full doses. If those patients that we should be keep in mind that are immobilized at bed, sometimes has lots of comorbidities, then you prophylactic doses. It's very strange. A couple of years ago, when I had the control by the police, which happens to me every third day, since when you go to the hospital and go back, there's also police controlling where are you going, and they asked me, "Oh, doctor, what is about this drug that make fluid the blood?" I mean, it's something that you use since probably 40 years. And it's everything I do believe is based on the clinical thinking. And also what you say, Xavier, I do believe it's really important. If it is a patient who has a huge risk factor for thrombosis, probably we should think about prescribing anticoagulation even after. And so always probably the clinical thinking should guide us, since unfortunately we do not have so many data.
Mm-hmm. Okay. So one more question is what we had actually challenged with. In some countries, if you have the continuous glucose monitoring devices, then it's easier. What we found difficult, this was to control for diabetes patients before the insulin injections glucose, because we didn't have enough stuff, and then every time the nurses needed to change. Do you have such issues, or is it done without any problems?
Well, I will say that we transfer all the diabetic patients to insulins during admission. So we have enough stuff to measure glucose. We do not use the permanent monitoring of glucose. It's not possible in our condition in the red zone, but we use insulin, and we did not see too much decompensated diabetes till that moment. Some of patients, of course, yes, but usually they are quite compensated due to our experience, at least.
Me too. I think that is the same experience like Valentin. We don't use special systems to monitoring. We do as regular we do. But of course, diabetes is one of the risk factors, and we have to be very aware of this patient. We will see now when more chronic patients and multimorbid patients will be followed up, how they will run, but not during admission. We maintain the same procedures than usually.
We do use the CGM in our group, since we have one of our colleagues and friends which is quite expert on these devices, and they use quite a bit. And also we go with the insulin sometimes. Just a small remarks about metformin. we are a bit afraid of sometimes the patients that are already taking metformin. And although I am a huge fan of this drug, very old and cheap, but very effective. But in this case, there's probably the risk of lactic acidosis or hypoperfusion. So we are quite, let's say, careful on the use of metformin in those patients.
Mm-hmm. Thank you. There's one more question. Honestly, I don't know whom to address about one drug, ivermectin. Ivermectin. Do you use ivermectin?
No, we do not use. There was just one paper from Australia came concerning these medications. It's mainly used in veterinary for dogs and cats. And it's used also like anti-parasitic and dermatological medication for human. And we had no experience with this medication for COVID patients.
No experience from my side.
Yeah, also, I think this is one of the, the story of ivermectin was that it was published by a normal newspaper, not by a scientific. And my impression in this story that is very, I think paradoxically, that scientific news goes first through media, mass media, than from scientific journal. We should keep an eye on it because, of course, patients heard lots of stories. And then they pretend they would like to have those drugs, but probably we don't have any scientific support.
One more, a bit controversial question about the drugs. Initially, there were lots of the news that NSAIDs should be avoided, sticking to acetaminophen more. And then I think in last webinar from Milan, Nicola Montano mentioned that in severe patients, sometimes acetaminophen didn't work, and still some NSAIDs were the ones who kind of were the ones pushing to the reconvalescence. How is your experience? Did you notice any difference or for
I will say that
non-steroidals?
we routinely use acetaminophen to our patient, and in most cases it works. We had not so much experience at the moment using other NSAIDs, anti-inflammatory agents, non-steroidal, but just a few analgin and some others, but not so much to make a statistical analysis.
Okay. One more about, there's a question in the general chat. Do you think that COVID-19 should be treated as HLH, especially in severe cases? Can any of you comment on this?
My opinion is yes, in this second or third week when you are totally convinced that you are under HLH syndrome. Because the fear is to decide when you have to treat, because it could be too early or too late. So the problem is when they use immunosuppressors and immunomodulators to treat this secondary hemophagocytosis, lymphohistiocytosis syndrome associated. But from my side, I am convinced that this is a secondary disease that has to be treated with the evidence that we know in those primary syndromes that, of course, if not, mortality could be 100%. So the difficulty is to decide the time when, but if you have all the parameters that supports the diagnosis, and the patient is unstable and severe, I am convinced that you have to treat it.
Then of course there's something about the repeated infections. How about the reinfection and immunity? What is your opinion? tricky.
I think this
tricky.
is the most provocative question because
$1 million question.
because we do not have any data at all. We can just say that due to my own opinion, that some of the patients get very strong immunity response and very high titers of immunoglobulins. How long will it consist? We don't know, but some patients had very low response, very weak response. Means that probably they get not enough immunity defense for the future. In such case, probably the reinfection can come. For today, as I know, there was just 3 or 4 cases described in the literature of patients who had the second episode of coronavirus. So probably it's like many other diseases. In some cases can have the second wave and second episode of the infection even in the same patient, but in some cases the strong immunity develops and protect the patient against the reinfection.
I think that is, of course, occasionally cases described, but I think that the idea is that we don't have till now evidence of reinfections. I have been reviewed how countries are now testing antibodies. I think that all countries are starting testing antibodies. It's not easy to find the perfect test, but in my own experience, we decided to perform digital tests to 200 healthcare workers. And we saw that those healthcare workers that had a confirmed infection, that was around 20 people of these 200 people, the test confirmed the immunoglobulins in different states. Most of them still had positive IgM and IgG, but some of them had only IgG when was more far from the beginning of the disease. But surprisingly, we achieved or we document around 10% of these 200 people that without any symptom being asymptomatic had the converter of antibodies. So probably now is the time that we will have more data around the world to understand how these immunoglobulins work, how these immunoglobulins stay, and now it's time to know more. But currently, my idea is that reinfection has been, of course, non-clear evidence to affirm that that could be only these few cases. No, most of them coming from China, I think.
Yeah.
Okay. There's one more question. Don't know where it's come from, but doesn't matter. How about early treatment started by GPs?
The problem is that there is no precise medications to stop the development of more severe forms. So we have only symptomatic medications for non-severe patients, and of course they should be prescribed by general practitioners. But if the situation, the condition will worse, of course only admission will help, because we can't administer, for example, tocilizumab or other immunosuppressors at home or by general practitioner. So the problem is that there is no specific medication to treat at home.
I read I think that 2 weeks ago a very nice article published in the New York Times that said that doctors are in this phase are treating emotions, not treating clearly any disease, because we don't have any options. So, and when we see now that hydroxychloroquine and azithromycin are not effective, probably we will have no options to give to our patients. So at the beginning is only support and symptomatic treatment, and of course a very close follow-up of all the vital things and symptoms to decide when this patient has to be transferred to a hospital.
I do believe in general, apart from the therapy, that GPs should be really supported in this story, apart from therapy, because they play a really relevant role. Probably if we did a mistake in Italy was, I mean, not now, in the past, that our healthcare system probably is too much centered and rooted in the hospitals. And we did not take care of GPs in supporting them. Probably this story should teach us that probably not only the hospital is crucial for the healthcare, but also we should make more efforts to support the GPs.
There's
GPs,
one more.
GPs will have a crucial role in before and
After.
later. No? After. Now is time to help them following up these patients at home after discharge. This is a very important role now.
And very important issue is protection of GPs in such situation, because usually the wearers are going to the masks are going mainly to the clinics, not to GPs, and then the number of infected GPs is quite high, as I know.
There's one more question about in this diagnostic phase about what about PCR for flu and other respiratory viruses?
We use it at the admission almost to every patient, but I think this is not important issue now because the epidemic of flu have finished already for this year, so it's not necessary. Indeed, we did not get no positive flu swabs.
Oh, yeah, I agree. Only an experience of mine that we have to maintain awareness of other diseases that can be similar to COVID. I remember a consultation of a young patient of 17 years old with fever, maintained hepatitis, and was confused to be a COVID-19 patient, despite him being negative in the PCR, and was a clear lymphocytosis in contrast with the lymphopenia that you are waiting in a patient with COVID, and was treated with all the Caletra, hydroxychloroquine, corticosteroids, cefazolline, was a confusion that of course the patient has mononucleosis and was a disease that still happens. So we have to be aware of other diseases that are not eradicated and eliminated.
That's really a problem that we are now suppose every patient as a patient with COVID, and sometimes forget that COVID is just a very small portion of all internal medicine diseases. And that's really a challenge, and it's important not to focus only on that.
Alberto, you wanted to add?
No, yes, absolutely. The point of Valentin was really important, and we probably should not. I mean, we should be aware also of the fact that we had a very fall down of the cases of myocardial infarction, heart failure, atrial fibrillation going to the emergency room. This will be quite a problem. This will be a tribute that we'll pay after, because we will see more severe patients with other kind of diseases.
There are 3 more questions. We probably try to wrap up, so to finish at past. just not to keep on eternally talking. And so there's one more question. This was addressed probably to Valentin. How would you explain the relatively lower mortality for this large population of the country?
There are several explanations. First of all, this is statistic, the official statistic, and it's calculating in every country, in every city, in every clinic by their own way. So I don't know how my colleagues will they join me or not. It's very difficult to rely on different statistical data, especially when you do not is it the real one or not, how it was calculated. The second explanation is more practical, that there is a delay between the increasing of infection and mortality, approximately 10 to 12 to 14 days. And we are now on the phase of growing infection, so the mortality will grow a little bit later. So probably we will see it not now, but in a few days. And the third point is that we have a strategy to treat the patients, and now I will say that this is our advantage, that we know a little bit more about COVID, comparing, for example, with Italy, which was the first under the heating. So probably we now using more anticoagulants, using other medication more often than it was in the beginning in Italy, in Lombardy, and probably this is also influent on the course of the coronavirus disease.
So two people are actually asking quite a similar thing. So there's a story about the people who have very mild symptoms or have received steroids earlier, and then they, after some month or even longer time, they are positive, and so like prolonged clinical course, if I understand this question correctly. Yeah.
Is there any high duration of COVID infection? Is it the question?
I understand approximately like this, yeah.
I will say that in our experience, the most long duration is approximately 1 month since the first symptoms. Maybe there are some unique cases when it can continue for longer period, but for my practice, for our experience, it's approximately 1 month. For most part of patients is 2-3 weeks usually, not more, not exceeding.
Yeah, I have the same idea. I remember patients of 28 days. I think that one of the issues is how the patient feels after the disease, after the acute phase. And most of them feel fatigue, with shortness of breath. That is not technically hypoxia, but is difficulty to recover the functional status as before. I think that this is very common in old patients, all those with chronic disease, that are especially difficult, the recovery after the disease. So it means that perhaps you can think that the disease is staying, but in most cases probably is the consequences of these muscle involvement and of course also encephalitis. And I have a case that is one of the youngest patients that after 1 month still has the IgM positive. So it's still decreasing, but this is still in this phase. So yes, probably the 1 month is the longest time that I saw in a patient.
Yeah, I do believe that probably these viruses can have also very wide-ranging tropism for several kind of tissue. Indeed, the ACE2 complex is spread in the whole body, and probably this could be the reason why we have so different kind of presentation, gastrointestinal, encephalitis, and whatsoever.
Mm-hmm.
There are two more questions from the chat, but they are more like clinical vignettes, and I don't know if we will manage to slightly to wrap the answer very briefly. So the one question is what to do with the older patients above 70 years of age, where tocilizumab is contraindicated in hospital protocol. What could be an alternative treatment? Steroids, heparin, in bed rest.
Sarilumab, probably Kevzara. We use it in such patients.
Okay.
We in our experience, we decided to offer tocilizumab in patients older than 70 in this very special and emergency situation. We of course take in account the contraindications like concomitant infection or level of platelets below 50,000, or other criteria that of course are clearly but comorbidities, that is the usual contraindication with this kind of patient. You have to decide to offer something, or death is the other option. So we decided, according to the ethical committee and the bioethics that we established in our hospital, to offer this treatment to these patients. We are now analyzing, of course, with a control group, what has been the evolution. But in our perception, many of them recovered without problems.
Okay. And the second comes from Madrid. Question: there's someone who has suffered recent severe COVID pneumonia, and now has the readmission for lung complication like necrotizing pneumonia after steroid and tocilizumab treatment. Any experience with severe COVID, severe complications, and second-line treatment?
No, from my side. I am of course worried about this possibility, and we are now following up these patients. But of course, some adverse events could happen after discharge, and we have to follow very carefully these patients. I didn't know any other case of necrotizing pneumonia, but it's really interesting to know about this, because now we could see the consequences of these adverse events in these patients when we achieved a follow-up over 30 days. That is when these effects can come.
Okay, and just very briefly, because before we are wrapping up and finishing today's, there's more about personal experience. How about dealing with social distancing and fear of not infecting your closest one? How about transportation to the work and dealing with this? Because if you live in a country where the biking is very good option and you have a small town or the private car, then it's easy. But if you need to use some public transportation, then it makes problematic. And the fear to infect your closest ones. What is your experience?
My experience that is I avoided any contact with parents, with my girlfriend, with close people, because it's a fear that it's in every day, in every second, you think you can infect your beloved, and you cope with it, hoping that this story will end someday. This is The public transport, I don't know, because I live very close to my hospital, and my life, it's just hospital, home, home, hospital, nothing more. So I think that there are some social distancing measures in Italy, and they're very, very, I mean, if you go to the streets, it's almost empty. So even in the metro, you find one person or two person, not more.
Yes, I feel very bad and very sad, this social distancing, because as Alberto said, the streets are empty, but also the hospital is empty. When you move on the corridors and the hallways and you see nobody there, or my service, my department, with all sessions canceled, all contact canceled, only contact by phone, by this meeting by computers, and this is very sad for me. In my case, I live with my family. I have 5 children. One is living out away from home, but the others came back to home, and is the contact that I have. But my mom of 82 is living alone, and my parents-in-law are living alone. I used to go to work with my own car alone. So I live very bad this social distancing, and I don't know how will be our near future, how all will change. And I am very worried about that, because in the case of my hospital, my department was very difficult to manage this isolation, because people need to have contact to share and to be together to share discussions and cases, and it's not the same.
I will just say a few words because I was a little bit more lucky than my colleagues. I live separate from my parents, but at this time I connected with my brother, who also works in the red zone of another hospital with COVID patients, and we are together for more than a month now. And of course I use personal car for driving to hospital, and I'm not afraid of to be infected, because it's a kind of destiny. It's a question of luck. Even if you use all your defensive suits and combinations and so on, and masks, means that you can get this infection by some other way. We do not know clearly all the possibility to catch it. So we are just trying to do our best to work and to protect as possible, as much as it possible. But I think we should not afraid. We should fight.
Good point.
Yeah, exactly. What I'm trying to slightly wrap, we didn't touch two tricky points. We didn't touch anything about the ACE inhibitor story. We didn't touch anything about the Swedish and initial UK approach about letting to get public herd immunity and versus strict social distancing. This is still, I think there would be too much fighting and too much controversies about this. From my side, I could say that we really, because in Latvia we started restrictive measurements very early and very strictly, and from the political level as well. Our doctors are more suffering with the so-called readiness burnout. So we are getting ready, we are waiting for the storm, and the storm is not that bad. The storm is somewhere close. They are the first line fighters who catch these more severe patients, but in general, these restrictive measurements have prevented all the other big closures of the hospitals, huge rearrangements. But psychologically, this readiness burnout is still there. And what I found very important, I think what helps all of us in every single hospital, country, and in a more general society, that to have a cooperation or support group. And being a part of EFIM, I have been a director of the postgraduate schools, and these alumni of the schools are organized in WhatsApp chats, and these chats are giving like sharing information and moral support and scientific support have proven very big help to me and to many of us. So whatever is your coping mechanism or support group, it's very important to survive somehow, to share your feelings, to share some questions, not just stay alone with your doubt and sadness and fear or anger or something. I'm for this night, or not night, it's not, it's evening here in Latvia or in Moscow maybe, but for this afternoon, I'm sincerely thank all three speakers, Xavier, Corbella from Spain, Valentin, Kokorin from Russia, and Alberto, Marra from Italy. I sincerely thank all the ones who are now listening till the end of this webinar, participated, asked questions, everything. Stay healthy, and as one of my best friends say, stay negative. Stay positive in your minds, but stay negative.
Nice.
Okay, good luck to everyone, and fingers crossed for all of you and your families and beloved ones. Okay.
Thank you, everyone.
Bye.
Thank you everyone
Bye.
for your
Bye.
attention.